Scenario: a 70 years old woman admitted with abdominal pain, initially diagnosed as acute diverticulitis, responded well to analgesia and antibiotics. She is complaining of severe right leg pain. Clinically, pulse rate irregular, blood investigation, right lower limb pale and pulseless, hypokalemia noted, ABG reveals metabolic acidosis. Other investigation, arterial duplex imaging confirm acute arterial blockage. ECG show atrial fibrillation. You are a CT1 vascular surgery working
General
with,
surgery.
yes, working with Mr. Lee. Call the vascular consultant to provide an update on the patient and request acceptance of the referral. Okay,
Okay.
so I will put 8 minutes and 40 seconds and we will start.
Hello.
Hello.
I'm Dr. Fatah Rahman, CT1 General Surgery, working with Mr. Lee. I'm calling to speak with vascular surgeon on call regarding acceptance for referral of patient with acute limb ischemia. Can I confirm I'm speaking with the vascular consultant?
Yes, you can call me Jack. Can you please summarize your case?
Yes. This is a 70 years old female which admitted with mild diverticulitis, showed response to antibiotic and intravenous fluid, but suddenly developed painful and pulselessness and pale right lower limb. Investigation showed mild hypokalemia and metabolic acidosis. We did duplex ultrasound for the limb, which showed complete block of the gluteal artery. So we are concerning about acute limb ischemia that we are need your approval, acceptance for referral for definitive treatment.
Why do you suspect acute limb ischemia?
Clinically, she has paleness, painful and pulselessness of the limb. And besides that, I forget to mention that the ECG showed atrial fibrillation, which is high risk for emboli formation.
Is it urgent
Yes.
and why?
As acute limb ischemia, early intervention is crucial for saving and prevent limb loss.
What is the earliest sign of ischemia?
Painless, painful, and severe pain, and paleness and pulseness.
Yeah, the pain is the first sign. So
Yes.
what a positive 2 points discrimination test indicates?
Positive 2-point discrimination means that the limb is viable.
What are the 6 P's?
It is painful, pain, pulselessness, paleness, boicothermia, paresthesia, and paralysis.
What does ubiquitothermia mean?
Hypothermia means coldness.
Do you need a cardiologist to review premature ventricular complex before transfer?
Of course, you need, but the priority now for saving the limb. I think they can assist later on.
What the suspected cause of arrhythmia in this patient?
Most likely electoral disturbance in the form of hypokalemia.
What do you think of her assumed diagnosis of diverticulitis?
As the patient showed atrial fibrillation and acute limb ischemia, so I'm suspecting mesenteric ischemia.
As a cause of her abdominal pain, okay?
Because of abdominal pain, yes.
Yes. Could it be mesenteric ischemia and why?
Yes, it could be because as she had acute limb ischemia and atrial fibrillation.
Okay. What are your other differential diagnoses?
Mesenteric ischemia and perforated viscus and infective colitis.
Do you want to scan the abdomen first?
Yes, you need to scan the abdomen, but I prefer to be after transfer.
What
I
imaging?
will,
What
I,
imaging?
I,
Continue your answer, please.
I will continue following and reassess the abdomen. And the abdomen now is soft with no tenderness. So I will consider to do CT abdomen after taking the renal function test.
Okay, and what imaging to do?
CT angiogram.
Okay. What will you do if the patient has contrast allergy?
I will do a magnetic resonance angiogram.
How to transfer your patient?
I will arrange to transfer in blue light ambulance.
What will you prepare in the ambulance?
I will prepare CBR set and searing pump for cardiovascular drugs.
What is your management plan in general?
I will correct the hypokalemia. I will administer.
Before the hypokalemia, doctor, what is your approach for this patient? You know, this patient has acute.
Yes. I will approach. I will start with critical care of early surgical patient approach. Then I will correct the hypokalemia by administering potassium chloride 20 to 40 ml in 1 liter of normal saline. I will continue monitoring with ECG and potassium level. Then I will give IV fluid 1 to 1.5 liter of Hartmann, and then I will correct the line cause for atrial fibrillation with hypokalemia, and I will use rhythm control, beta blocker, and rate control, beta blocker, and rhythm control as imidazole. Then I will administer anticoagulants. I will use loading dose of 5,000 of unfractionated heparin. Alternatively, I can use intravenous loading dose of 75 units per kg, then followed by 18 unit per kg per hour as a continuous infusion. I will monitor with activated prothrombin time in daily base. Then I will shift to low molecular heparin as tinzabirin as a treatment dose.
Okay. How would you inform the family about the patient's condition and the need for urgent intervention?
I will explain that the patient is experiencing blocking of her circulation, which is give a risk for the limb loss. So she need urgent intervention. So that way I need to transfer to the vascular surgeon for definite treatment.
Okay, thank you for your update. You can refer with your referrer.
Thank you, Mr. Jack.
And you
Thank you
can
for
go
your
to the
time.
next session.
Thank you.
You have 1 minute and 20 seconds. I think this is the last question in this session. Ali, you can start. Please unmute yourself.
Ar-Rahman, very good.
Yes,
Very excellent.
Very
Thank you,
excellent.
sir.
You are very fluent. Even you changing some of the words from school, but you put it in the right way. Like my patient is experiencing this and that. And you can say he's experiencing this and that, or he experienced this and that. So a huge improvement. Please watch your performance now and watch at the start.
It's very different. Very different.
Yes.
Significant different.
Of course, this is a bus for this station. There's small beep and bops. Can I confirm? You said, can I confirm I'm speaking? No. Can I confirm? Am I speaking?
I'm speaking with this.
Not am. Am I?
Am I speaking with yes?
You said investigation showed. You can say our investigation showed or revealed. Revealed is a bit nicer. The positive, when he asked you about the 2-point discrimination test, you said 2-point discrimination test indicates viable limb. You are not wrong, but that's not specific. You should say positive. 2-point discrimination indicate viable limb. Because if it's negative, that means it's not viable, right?
Yeah, yes.
Yeah. The question is repeated. We just want to train you that even if your examiner asks the question twice, you just answer it. Muhammad asked you the question twice.
Yes.
In a different way, yeah.
Yes, in a different way.
Yes.
You said you need to scan. No, we need to scan. You are speaking to yourself. He didn't accept the referral yet. So how the NHS work? Before the referral, the patient is yours.
Yes, I need to scan.
You said, yes, I need to scan, instead of you need to scan. Muhammad reminded you of CRISP, but in the exam, they will not remind you.
They will not.
Yes, and as we said, we put it as a CRISP in the school, but you shouldn't say CRISP. You should say care of critical illness
surgical patient.
And you said that there's no problem about that. I just want to ask you, do you know the maximum of potassium per hour? How much you can give per hour? Let's say this is a new question on the exam.
I think 1 mil equivalent per kg per hour.
If I want it in millimole, you said you will give 20 to 40 millimole per hour. 20 to 40 millimole in 1 liter.
In 1 liter.
What is the maximum millimole per hour? 10.
10 خلاص.
According to the NICE guideline, 10 millimole. It may differ in your practice, but the maximum is 10 millimole per hour. If that was a new question, but I don't have any other point. That's a very good presentation.
Yeah, very nice presentation, Fatah Rahman. I think you mastered this station. The only point that I would like to mention, I think Ali mentioned it before me, which is about care of critical illness surgical patient. You should mention it because your patient
very
is
important.
critically, yes.
It's very important.
Yeah, otherwise, I have no any comment. Very nice presentation. You mastered the station.
Thank you very much. Thank you.
Should we go to the next station?
Yes.
So let me back to school.
Perforated viscus, right?
Perforated viscus. Yes.
يا سؤال يا علي ومحمد قبل ما نبدأ في
English.
Is it about the exam?
Yes, not about the exam, about the station, about the dose of potassium.
Yes. Yeah, tell me.
The first dose is 20 to 40 ml, right?
Yes.
And the maximum dose is 10 millimole per hour?
Yes.
Okay.
Maximum dose is 10 millimole per hour.
Okay, thank you.
So the next station is perforated viscus. Ala, please unmute yourself. Scenario. Mr. Wilson is a 71 years old man with a background of COPD for which he is taking steroids. He developed perforated viscus and acute renal failure with hypokalemia. Clinically, he has severe abdominal tenderness and rigidity, abdominal distension. Additionally, he is hypotensive and tachycardic. Blood test, ABG shows metabolic acidosis with a high lactate and high negative base excesses, hypokalemia, high creatinine, hemoglobin dropped 2 units. Imaging, ultrasound showed free intraperitoneal fluids, chest X-ray, clear with no air in the diaphragm. Your task, you are SHO in University of Birmingham Foundation Trust, working with Mr. Jack. Call the ITU registrar to seek advice and inquire about the availability of an ITU bed. Do you follow me, Ala?
Yes.
Okay. So let me put the timer. You can start.
Hello, I'm Dr. Ala, the SHO working in the Birmingham Hospital with Dr. Jack. I would like to speak to the ITU registrar for advice on a patient who is recently admitted, needed laparotomy. May I confirm who I am speaking with?
Yes, I am the ITU registrar, and you can call me Mr. Allison.
Okay, nice to call you Mr. Allison.
Nice to meet you, doctor. Can you summarize your case?
Yes, of course. My patient is Mr. Wilson, a 70 years old male, known case of the COPD. COPD and perforated viscus and acute renal failure. Clinically, he is hypotensive, tachycardiac, and suddenly exhibit an severe abdominal pain, severe abdominal distension, and tenderness. He is the blood test show hypokalemia, high creatinine, and metabolic acidosis with high lactic acid, with high lactate, and abdominal ultrasound showed free intraperitoneal fluid, and chest X-ray was clear.
Doctor, you mentioned that your patient has COPD. Did you check his oxygen level?
No, unfortunately, but I will check the oxygen after finish from this call, and I will update you immediately.
And how will you give O2 therapy?
Okay, I will give by Venturi mask or nasal cannula for liter of oxygen. And if it was mentioned in the file at 28%, I will increase to 35%.
Is it mentioned in the file that the percent is 28?
Yeah, I said in case of is it 25, I will increase to.
Why this approach?
Because I'm afraid of respiratory depression, as his respiration driven by hypoxia.
Will you repeat ABG after giving this oxygen?
Yes.
What are the medications your patient taking for COPD?
He's on arbitrol, fluticasone, and Ventrol.
Any plans regarding the steroids?
Yes, yes, I want to administrate hydrocortisone 100 IVMG.
Was an ECG performed for this patient?
I'm not sure, but I will check and update you. Sorry.
If available, what findings are expected?
I'm expected to see an atrial fibrillation manifestation yes, for hypokalemia manifestation.
What about fluid balance? Any chart taken?
There were not a chart available, but for fluid, I will provide 1 to 1.5 liter Hartmann solution, and insert urinary catheter and monitor the urine output.
How will you monitor his response to fluids?
I will monitor by heart rate, blood pressure, urine output, capillary refill, mental status.
Was a urinary catheter inserted?
I'm not sure, but I will double check and update you.
Who else would you contact beside me?
I will contact to the anesthetist and registrar anesthetist and the general surgery consultant.
Did you give your patient antibiotics?
Not yet, but I would like to take a blood sample for culture and sensitivity, and I will discuss with the microbiologist to provide appropriate antibiotic.
Do we need to give the patient more blood because his hemoglobin is going down?
Possibly, but I will ask for blood grouping and cross matching, and I will discuss with the hematologist for more advice.
What is the treatment of the atrial fibrillation of this patient?
I will treat the underlying cause and correct. Yeah, I will correct hypokalemia. Correct hypokalemia at the underlying cause and give and control a rate by beta blocker and the rhythm by amidaron.
Is ICU admission necessary for this patient?
Yes, because given and COPD and acute renal failure.
What if only one ICU bed is available and an asthmatic patient arrives first?
I will wait. I will monitor my patient in the ward recovery, and I will wait until the bed available.
Is the surgery risky for this patient? You mentioned your patient has COPD and renal failure. Is the surgery risky?
Yes, this surgery has a significant risk, but it is essentially unnecessary for his condition, and the preoperative optimisal is essential.
Okay, this is the last question. You would like to add anything, doctor?
Yes, I would like to mention his hemoglobin. It was dropping 2 unit, and I was asked to coordinate a bit post-operatively.
Yeah, proceed with your patient and contact the anesthesia registrar and the general surgery consultant.
Okay, thank you. I will update you by anything new.
Okay, thank you.
You're welcome.
You have 1 minute and 20 seconds.
I don't have anything to add.
Okay,
Yes,
Ali,
good.
you can start.
Yes, I will start from the end. Whenever you feel that you answered all the question, don't add anything. You're just gonna tremble, and you're just gonna say nonsense. So if you sure you answered all the question, then that's fine. Say I don't.
Ali, before continue, I would like to add a point in this point you mentioned. When you finish your station, you can just summarize your plan of management and thank your consultant.
Yes.
So I will proceed by administer fluids, insert a catheter, optimize steroid, monitor ABG, administer antibiotics, and so on. Thank you for your time.
Don't talk too much though. If you talk too much, that will make you make mistakes. Ala, very good. There's a huge improvement from the previous, and of course you pass this station. There's a small mistakes. You said, can I confirm who I am talking to? But you should say, can I confirm who am I talking to? As we said for Fath al-Rahman. You said, I want to administrate. Administration is like managing, but I want to administer, not administration. Okay? So it's not I want to administrate it, I want to administer this. You said I'm expected to see. You better say I'm expecting to see this and that. You said I will correct all hypokalemia. Did you notice? You mixed some Arabic with English. You said I will correct al hypokalemia. Instead of I will correct hypokalemia. You said I will correct al hypokalemia. And preoperative optimization instead of preoperative optimization. The end result, this is a bus. That's a very fluent station. You answered all the question right. I just want to ask you, the pathophysiology for patients with COPD, why don't we give them oxygen? This is not for you, Anna. This is for anyone who knows. Why do we give between 88 to 92 SpO2 instead of making it normal, above 94 for COPD patient?
Ahmad, I think you want to answer.
Yes.
Yes.
Because COPD patient has no the respiratory center in COPD patient not to respond to oxygen. It's about CO2 decrease.
The respiratory center in a COPD patient respond to what?
Hypoxia only.
To hypoxia.
Respond to hypoxia.
Yes.
Okay.
To see
And you don't have COPD, right?
what?
Ahmed,
Yes.
you don't have COPD, right?
No.
Okay. What's your respiratory system respond to then, as a normal
No.
person?
Respiratory system in normal patient respond to hypoxia.
Hypercapnia.
But in
CO2.
CO2, increase in CO2. Hypercapnia.
pH center.
For the normal patient, it respond to
To hypoxia.
The higher
Hypoxia.
center
No.
responds to hypercapnia, and the
The
peripheral
opposite.
for hypoxia. The
Yes,
opposite.
exactly. So look, you as a normal person, your respiratory center respond to hypercapnia.
Yes.
When there's high CO2,
CO2.
then you will breathe.
Hyperventilate, yes.
Yes.
Me and you as normal. But those patients, because they have COPD, they always in hypercapnic
Capnia.
state.
Yes. The center is
This will
adapted to hypercapnia.
This will lead to intolerance in their receptor. I want you to think about it. Imagine you have a receptor in your brain and the CO2 is always high. You will develop intolerance. If someone is smoking for years and years, he needs more smoke, right? He will develop the intolerance. Because they develop intolerance to high CO2, now their respiratory center completely depend on the hypoxia for them to breathe. So during the clinical setting, you make them hypoxic. You make them between 88 to 92, which is not the normal.
Not fully oxygenated, yes.
Then you understand it clearly, Ahmed, right?
Yes.
Yes, I think you already know the idea, but you just mix it up. Okay, fine.
So
Respond to hypoxia, the COPD patient. Yes.
Yes.
The COPD, yes, respond to hypoxia. That's why we keep them hypoxic. We iatrogenically keep them hypoxic. Okay.
The normal patient to CO2.
Yes.
Yeah. Ala, very nice presentation. I have no any point to add. You are improving, and I have no any point. Should we go to the next station?
We finished the history and the communication. I have 4 or 5 people contacting me about the communication. They feel they need some help with it. I think this is the appropriate way to do it. There's 4 people contacted me, felt because of the skills and their communication mark was not that high. So our way is the best way, and I'm encouraging you to continue the same. But please, in your free time, for example, you don't have session tomorrow, you don't have session on Friday, you don't have session on Thursday. Please study the knowledge.
Okay.
On your days off. Okay.
Inshallah.
So the last station is update trauma head is Al-Fatih.
Yeah.
Scenario: 21-year-old male involved in RTA at 5 a.m. He experienced transient loss of consciousness. His GCS initially 15 and hemodynamics is stable. Physical examination showed swollen right hand, left upper abdomen abrasions, open tibiofibular fracture on the left lower limb. Investigations: X-ray revealed fractures in the right hand and left tibia and fibula. Abdominal ultrasound showed a free intra-abdominal collection. Blood test within normal range. Intervention: you administered tetanus and antibiotics and fluids for this patient. At 1 p.m., the left leg showed signs of acute limb ischemia, which is absent distal pulses, dullness, and worsening pain. Your task: you are a surgical clinical fellow working with Mr. Jones in Royal Free London. Call the trauma head and update him about your patient. Okay?
Okay.
So let me put the timer. You can start.
Hello, I'm Dr. Al-Fatih Ahmed, one of the surgical fellow working Mr. John in Leicester General Hospital. I'm calling trauma head consultant to update him about trauma case. May I confirm that I'm calling Mr. Borto,
Yes, I
trauma head
am.
consultant?
Yes, I am Mr. Porto. Can you please summarize your case?
A 21 years old male man presented to the hospital after RTA at 5 a.m. On examination, his Glasgow score is 15 at the present. In spite of he has the history of transient loss of consciousness. Clinically, he is hemodynamically stable, and he has the left right hand swelling and left leg open fracture and abrasion in the upper left quadrant. His examination reveal his chest X-ray reveal fracture right hand and open fracture tibiofibula in the left leg, and the ultrasound showed pre intra-abdominal collection. At 1 p.m., his left leg show a sign of acute limb ischemia, as it look pale, swollen, and tense with pain out of proportion.
Okay, doctor, what is the most urgent issue with this patient?
The most urgent issue is acute limb ischemia.
And why the call made?
Because acute ischemia, he may need urgent intervention to save the limb.
What are the causes of a pulseless foot?
Number one is vascular injury. Secondly, the compartment syndrome, and maybe kinking due to kinking of vessel.
Why was an ultrasound requested for the abdomen?
Because there is abrasion in the left upper quadrant to exclude the splenic injury.
What's the approach if there is free fluid in the abdomen?
In this case, the patient may need urgent laparotomy.
What is the missed investigation?
Duplex ultrasound and CT angio, and also CT abdomen and pelvis and head.
Because this is a polytraumatized patient, okay?
Yes.
Is the patient wearing a C collar?
I'm not sure, but I'm so sorry for that. I will check and let you know.
Is your patient dehydrating?
This information is not available, but I will double check and apologize again, and we'll let you know.
So, doctor, can you tell me how you will approach this patient in general?
I will manage this patient according to advanced trauma life support, approaching ABCDE. I will inform my senior surgeon consultant and also orthopedic consultant, and also vascular and anesthetist and theater team.
Can you
And
mention the
immobilization.
ABCD?
I would like to add immobilization of fractures. The airway, A for airway, maintain an airway and give oxygen if it's needed. B for check the breathing and give oxygen and check
How you will
oxygen
check the
saturation.
breathing?
I will check the breathing by pulse oximeter.
And how you will check it, the airway?
I will check the airway by look, feel, listening, look for any obstructive for foreign body, and check the airway if it is open, and then maintain the airway open and triple
You
fixation.
said look, feel. You
Yes,
said
look,
look
feel.
to the, yeah. What's about the feel?
Feel for breathing in my cheek
The chest movement.
and chest movement, and
Yeah.
also okay.
Okay, doctor. And what needs to be done before sending the patient to the theater?
I will give him oxygen, airway, oxygen, IV fluid, antibiotic, anti-tetanus, and then I will mobilize the fracture by splint or cast and cover the fracture without wash and wash in theater within 24 hours.
And what are the necessary blood investigations you will request?
Blood grouping, cross-matching, and CBC, RBC, CBC, LFT, and LFT, urea electrolyte.
Okay, how to fix the fracture and why?
I will fix fracture by external fixation. It is provide primary stabilization, and then it is provide access for secondary intervention to fix the tissue damage.
Who may need to be contacted before or during the operation?
I will contact the consultant, the orthopedic surgeon and general surgeon and vascular surgeon and anesthetist.
What else?
General surgeon, orthopedic surgeon, vascular surgeon, plastic surgeon, anesthetist.
Why you will contact the plastic surgeon?
For possible graft upon the open fracture.
And why you will contact general surgery consultant?
To manage the wound with open fracture and rule out possible abdominal injury.
Compartment syndrome. Okay.
Compartment syndrome.
Okay, thank you for update, doctor. Proceed with the management. Start by ATLS and update me.
Thank you very much for your time.
We can go to the next session.
Thank you very much for this time, boss.
All right.
Have 1 minute and 15 seconds.
I will proceed by approaching patient according to the ATLS protocol, approaching ABCDE, and giving IV fluid, antibiotic, anti-tetanus, and immobilize the fracture, and cover the wound, and inform my consultants and orthopedic consultant, vascular, and anesthetist, and plastic surgeon.
Okay, thank you, doctor, for your update. You can go to the next session. Time up.
Thank you very much.
All right, good, Al-Fatih. Very good, very good. I think you answered all the question in a good way. At the start, you're gonna pass this station, obviously. There's a small mistake. You said I would present this male, and you said man.
تعرف يا علي، انا بس لانه مجهز احساسي الليل والصباح انه انا هشتغل البرفوريتد فيسكس.
ايوه
عرفتها. ريحتها كم مره، لكن دي ريحتها امبارح سريع كده على اساس انه انا ما هقدمها.
Okay, if you say the male, don't say man. Long story short.
ما انا غيرت رايي لمان.
Okay, male or man. Okay, his chest X-ray. You said his chest X-ray revealed, but his chest X-ray revealed at the.
انا قلت ريفيل، اقسم بالله قلت ريفيل، انت ما سمعتني.
No, والله الليله اللي اجيب الريكورد. الليله محمد.
ليه قلت شوت؟ ما كان اقول شو.
No, قلت reveal and his left leg showed. These are only two very simple mistakes that I don't think they will count. I don't think you will lose any numbers by this. But otherwise, you did very great station. Yes, Mohammed?
Yeah, Al-Fatih, very nice presentation. Excellent, more than excellent. You must have a station. The only point I would like to mention, Al-Fatih, in the patient of critical ill surgical patient, we can mention ABCD approach quickly without mentioning airways, curing, management, and so on. But in traumatic patient, when the examiner asks you about the traumatic patient, how to manage this patient, when you say ATLS, you should mention ABCD approach by details. We'll check for airway, check for breathing, check for circulation, disability, exposure, and so on. You should complete the ABCD approach.
Okay.
So in patient with acute pancreatitis, I will start by I will treat this patient according to the care of critical ill surgical patient. I will start by ABCD approach. Then I will not mention the ABCD approach in details. I will go to the management of the acute pancreatitis specifically, okay? Did you get my point?
Okay.
Okay, otherwise I have no any point. Very nice presentation. You must read.
I just want to add one thing. Ahmed, you sent me an image before. I'm not sure if this resolved or not. But from now on, if you have any question or any discussion, put it on the group. Like, for example, the image you sent to me, say
Send
this
it in
image.
the group, yeah.
Yes, this image need to be added to the Telegram group. So everybody will
Okay.
know, and Muhammad will see it, and I will see it.
Okay.
I'm not sure, did you send it to Muhammad or no?
No,
Just
I
put it
didn't
for,
send it.
yes, just put it in the group. And Muhammad, we need to add a CT scan to
Yeah,
one
I
of
will
the
do. I will do it. I will do it.
Okay.
Congratulations,
Otherwise,
we finished the communication skills, guys.
I think Fatih forget to involve the neurosurgeon in the operation.
The neurosurgeon.
اي والله ما قلتها
Yes.
صح كلامك صح
Yes,
شكرا.
لا هو forget لكن فتح الرحمن ده بناقر في الفاتح ما عارف
لا والله. We are reminding each other. He will not forget it.
شكرا لا شكرا علي ما تبقى هنا.
I'm 100%.
try to prepare for the examination. We